service. I will try to give you an idea on how we work with chemoembolization of the lung, and my second talk will be ablation, and there will be some cases I show where we combine both techniques. The unit is on service. I will try to give you an idea on how we work with chemoembolization of the lung, and my second talk will be ablation, and there will be some cases I show. You hear me well?
Yes,
do you
yes,
hear me?
Yes,
okay.
Yes, we all can hear you.
Okay, then I go further on. Looking at intraarterial therapies of lung tumors, I will define with you what is regional therapy. We will define how different methods are working, and I will show with you and share what is the technique, how to proceed with these techniques. In our oncology unit, of course, in lung tumors, we have to consider different techniques and technologies, and this includes a lot of clinical data on receptor status, mutation, biomarkers, previous therapies, patient preference, and location of the tumors. How we decide whether a patient might be a candidate for a systemic, a local, or a combined therapy. So in our tumor boards, we look at the tumor entity and tumor biology, the stage of the metastatic disease. If you look at lung metastases, we need data on chemosensitivity of these tumors, growth dynamics, resectability, curative or palliative approach, or neoadjuvant strategies, which might be, for example, downstaging, downsizing, followed by resection. The first technique which is used for lung embolizations and chemoembolization might be transarterial bronchial embolization. By this technique, the bronchial arteries are selectively with a catheter approached. Most of these arteries arise between TH5 or 6, what you all well know. Often we have two bronchial arteries on the left side and one on the right side, and the easiest way to find them is the posterolateral aspect of the aorta. A typical example you see here on the left-hand side in the bronchial artery evaluation. But what is the problem? The
Dr.
challenge
Vogl,
of...
Dr. Vogl, please can you just can you make it full screen?
What can I make?
Yeah, full screen, PPT and presentation mode.
Full screen, yeah, I can make full screen.
Yes, sir. Yes,
so,
sir.
So better?
Yeah, no, still not. You just have to click on that presentation mode, full screen mode.
It is better now.
Yes. Now it is. Okay. Now it is okay.
You know, and here you see the problem in the bronchial arteries, which is shown here. You see that we have connections to the spinal artery, especially to the anterior spinal artery. So each intubation of the bronchial artery comes along with a risk of having also spinal cord ischemia, which might result in paraplegia. So if these bronchial arteries are of a small caliber, it's a really challenge to inject drugs there, and you have to be extremely careful and exclude via angiography that you don't have any connections to the anterior spinal cord artery. This is why our major interest was to the isolated lung perfusion. There are data already available from 2007 in rats. They treated pulmonary metastasis from soft tissue sarcoma. They had been using doxorubicin, and they found that the lung tissue levels of these drugs are much higher. In that way, that might be a basis for further treatment. So Schneider and his group in 2007 also used it in a pig model. They also used carboplatin of the lung. And so currently there's a lot of studies done for this treatment, like the group from Aachen. They evaluated the safety of this technique and in a porcine model and found out that there's only a mild or temporary increase of the pulmonary pressure, normally no irreversible pathologies in the lung and no ischemia of the brain. So they found out, and this was used also for further studies, that this is a quite safe technology. So if we go to the lung, which means we go in a venous approach to the lung and pulmonary arteries, we have to know that we possibly have a reduction in the blood flow in the pulmonary capillaries, and there might be also toxic damage. This is shown also here because we are changing the velocity of the erythrocytes and the capillary permeability. That might be changes. How we perform this type of treatment? So we are inserting normally a 5 to 6 F sheet. We are super selectively going to the pulmonary artery, supplying the tumors. We are using angiographic, high-resolution angiography to exclude pulmonary shunts. We can place balloon catheters. It's not absolutely necessary. And these are the drugs which are currently under evaluation: mitomycin, gemcitabine, cisplatin, and you can embolize either with lipidol, or you can either embolize with microspheres like Embolization. So the technique is quite safe. It is done percutaneously. You can do selectively, you can do bilateral, and you can repeat it. And of course, you should have some imaging before in order to exclude that there is not a pulmonary embolism. Here again is a shown example, especially lower lobe tumors, which are larger, are ideal for their technology. It's a quite easy access. You can here block the segmental artery with a balloon so that you have a high concentration of the chemoembolization material in order to approach the tumors in a safe way. What we also do is we always do a dyno-CT before we are injecting, and we had been able to show that with the dyno-CT we can get ideas on the permeability of the tumor. So we are analyzing by rotational use of this dyno-CT, we are analyzing the blood volume perfusion, and we found that quite helpful, and this is also part of our studies. I want to share you an example. A 71-year-old male patient. He had pulmonary metastasis lung cancer. Initial tumor stage was T2 and 1. Here you see the dyno-CT, which is shown here. Out of the angiographic unit, you see here the tumor itself, the recurrent tumor, which is presented here. And in the blood volume analysis, you see that there is a high degree of vascularization in the hilus, while the tumor itself, which is shown here, has a lower impact in the permeability of the tumor. And so as an example, you see the patient here with one of the metastases before treatment, after the first TPCA, the second and the third TPCA. So we were able in these tumors to have an exact downsizing of the tumor, enabling then further strategies like either lung resection or thermal ablation. So this is currently what we are analyzing. Here again, the example in the dyno-CT. Let's go. Another example, when we do chemoembolization of the lung using DSM, especially we like that technology in patients with multiple metastases, if they are in the right and left lobe of the lung. Here an example of a leiomyosarcoma. The patient had a high tumor burden, and after 4 cycles of TSMN, TPCA, we were able to, at least oncology-likewise, to induce a partial remission. Here's an example shown, a reference lesion here in the left lower lobe, segmental artery segment 7 and 8. So we were able to intubate, have a small balloon here, injecting the chemoembolization drug. The concentration after the lipidol uptake is shown here in the CT scan with a high uptake of the lipidol, which was well demonstrated. And here the further course, second and third TPCA, the tumor was significantly lowered in volume, which was quite successful. And we had been able for this patient to further consider then technologies like ablation, stereotactic radiation. This was then again discussed in the tumor boards. We also tried the drug-eluting beads in the lung tumors because we thought that we would be then able to use a lower dose of administrative material in these patients. Here you see, however, if you use the beads, we had the response rate was much lower, and we also saw some complications. So the application of beads in the pulmonary artery was in our series both not successful and also associated with higher side effects. If you look at survival, what is these chemoembolization of the lung doing? If you use DSM or lipidol, we see that we had, at least in those patients, in general, a median survival time of 56 weeks and a 1-year survival rate of 72%. It was the initial series. I will show you later some new data on the lung malignancies. Currently, our experience is mainly on metastasis. You see the far most is colorectal carcinoma, because we see them also for the liver work, breast cancer, sarcomas, and the other one are primary lung tumors. You see there's a nearly equal range between male and females, about the 300 patients. If you look at the survival, of course, what we expected in these series that we have in the lung cancer, lower survival rate than like in the patient with colorectal cancer and breast cancer, but this is mainly due to the overall data. What we found also in comparison, if we performed chemoperfusion by the bronchial arteries or by the pulmonary arteries, that our survival data were worse in comparison to the embolization. So these data prove our theory that combining the chemoperfusion with embolization of embolization material is an advantage for these patients. Another example, which is shown here, a patient here with a lung neoplasm in the left lower lobe. The patient is also suffering from a kyphoscoliosis, and you see after 3 courses significant downsizing of the tumor here at the final end, and making this candidate then a good option in the tumor board for discussing, for example, thermal ablation like microwave or cryo, I will mention later. What we also found very interesting is that MRI, using diffusion weighted MRI, helped us in the pre-decision phase. Here we see a high signal intensity due to a high ADC value, which normally goes along with a good response to treatment. Here you see the ADC values calculated here. So we found that those patients who had ADCs values around 0.9, which is seen here, mostly had a better outcome in the local tumor control than those patients with higher ADC. Interestingly, if we look at these ADC values, there's a cutting range. Currently, we are having this data, but you see the specificity is still 80%. But at least if we are able to increase the ADC value by our local technique, it looks like that we can improve the survival in these patients. Another example of a patient with the bronchial neoplasm, shown here, a huge tumor. The patient had already dyspnea from diaphragmal infiltration, and here you see the catheter placed in the inferior lobe artery. We did it 3 times, and you see also after lipidol chemoembolization that there was significant downsizing of the tumor here. Still some tumor mass remaining, but at least from a clinical point, this technology was able to give the patient a palliative treatment option. Here again, the overall survival, which I showed you before, in the primary lung tumors, if we analyze the very selectively mentioned patients, or in the secondary lung tumors, we see in the long term that the lung cancer patients who survived the first 2 or 3 years were a little better in concerning the overall survival curves. What are clinical studies done so far? In the first series, we evaluated our patients for palliative and neoadjuvant treatment, 143 patients over a period of about 10 years. Palliative setting was mainly, mortality was 0, technical success rate was quite good. And what you see here, that we had stable disease in about 66%, progressive disease in about 20%. But you see about 2/3 of the patients are at least quite stable very low number is partial response. These data also showed that we, in those patients where we used chemoembolization of the lung neoadjuvantly and then ablated, they had a better survival than a palliative patient. In a way, we suspected this also. Here the data are shown also in the subsequent ablation group, and this is now under press in European radiology. Here for the survival, it's again shown that those patients, you see here PED, progressive disease, they are immediately showing a decrease in the survival rate. And here after 30 months, nearly all patients had been died from the disease itself, while in those patients who showed the stable disease or partial response, the survival improved significantly. Here's again for the number of nodules. Always a question, makes it sense to treat patients with 3 or 5 nodules or even more nodules? And you see that those patients who had less than 3 nodules per lung, they showed the best survival rate, while those patients with more than 15 or 16 lung nodules, they were very low in survival. This is expected, but these graphs prove this theory, what I mentioned here. A little devastating slide here. It shows you that, of course, in our series, we had a collection of different other underlying histologies like head and neck cancer, renal cell cancer, but these numbers are too slow to evaluate. And the only good data we have for colorectal cancer, breast cancer, and sarcomas, which are helpful. Also, interestingly, we found a difference, which is shown also in the watershed diagram on the right side. If we had patients with unilateral metastasis of the lung, they were significantly better than those patients with bilateral. Very interesting. This is not published so far in the surgical literature, but we have been surprised how big the difference was. Maybe a bias, we are not sure about that. What is about the neoadjuvant chemoembolization? Here we had in the first series 36 patients, and then we downsized the tumor, and then we treated them with microwave in these patients. And here an example is shown here, a 50-year-old patient with 3 colorectal lung metastases. We decided for lung chemoembolization because this tumor was very near to the vascular main structure of the lower lobe. So we were quite afraid that we get here substantial bleeding during ablation. Here the angiographic, the placement here of a picture catheter in this patient. Sorry, I went back here. I go forward with the slide, and you see here the tumor after chemoembolization significantly downsizing. You see some linear stripes. This was after microwave ablation. We made a big hole here. And you see some surrounding edema. I will mention later in my ablating part, but at least we were able to control this tumor for a long period. Another example, 70-year-old patient suffering from unilateral lung metastasis. He received the TPCA, and also here the patient showed these lesions. We were long discussion in the tumor boards whether to perform chemoembolization first and then do ablation. And you see here after the first treatment, it was even a little larger in size also here. But after 2 months, we were able to downsize the tumors. And from the biology, we had the feeling that this patient might then benefit from the thermal ablation. Here you see we did it here with the microwave ablation. You see the ablation lesion itself. 12 months after ablation, we see a little bulla, which is shown here in the little surrounding structures along this part of the metastasis in the lung. So combined therapies might show some probability of survival. This was what we had been in monotherapy and the combination therapy. Those patients who had only microwave, they were better, but of course they had smaller lesions in size and they were better from the biology. This was shown in evaluating those data. So if we summarize for the lung metastasis, if you're using chemoembolization, we see that those patients who have no subsequent ablation, only chemoembolization are much lower in survival in comparison to those who are receiving chemoembolization and ablation. More complex is the situation on lung cancer. We have now meanwhile treated a group of more than 100 patients with unresectable primary lung cancer. They underwent chemoembolization, a mean of 5.3 sessions. Here you see the age groups. Most of the patients older than 60 years, equal female and male, unilateral 65, bilateral 53, and we had also some underlying situations. Here an example of a patient with the lung cancer infiltrating here in the upper lobe and the paramediastinal infiltration. Here we see the application of the catheter and the positioning of the chemoembolization drugs, which are shown here. The results here are more complex. Why? Because of course, in the lung cancer, the bronchial artery application is often more complex. Some of the cancers completely close the bronchial artery, and this is how we compared chemoembolization and chemoperfusion. And we saw in the first series here that these two technologies are nearly behaving the same. So in the overall survival, long-term survival, there was not a big difference. If we look at the first date of survival, we had those patients with a little better survival who were evaluated with a bit better prognosis. So these patients were pre-censored and they were a little better in survival. So chemoembolization proved to be a little better than chemoperfusion with these patients. So I want to summarize for our chemoembolization protocol. If you consider that technology, chemoembolization with either DSM or lipaidol is very safe. It's repeatable. It's, in our opinion, indicated for palliation or symptomatic situations. What we think, it has quite adjuvant potentials. So if you are able to downsize your tumors, you might be able to get more patients for your ablative practice. And so we have currently been very lucky that we initiated a study in Frankfurt where we compare chemoembolization and chemoperfusion prospectively in a prospective randomized protocol. But of course, as you can imagine, it will take 2 more or 3 more years to get really data from that. I want to switch to also to some of the side effects, which are shown here. If we combine chemoembolization and chemoembolization, we see that we had some patients with dysphagia, what we have seen after chemoembolization if we combine it with ablation, no spinal problems. My second part, if I have some time left, yes I have, will be on the thermal ablation of lung tumors. Thermal technologies which are available currently is radiofrequency ablation, microwave, laser, or cryotherapy, which has recently got a major interest again. Some groups are using HIFU, ERE is a technology, or of course our friends from radio-oncology. I'm a trained radio-oncologist before, so I know these technologies quite well. I mainly want to focus on clinical data, but just to give you, for those not so experienced with microwave ablation, the good thing with microwave ablation is that we avoid tissue carbonization, and especially in the lung, this technology is working very well. It's nearly painless in comparison to RFA, and of course, what you have to achieve is at least a temperature 60 degrees and more. Here, a patient with colorectal cancer. He underwent left hemihepatectomy, and he presented with 3 pulmonary metastases in our tumor board. And I show you the 3 metastases which were shown in the board. So they offered me this patient with a metastasis on the left lobe. There's one on the right side and one on the right side. And this was before ablation. We performed chemoembolization to downsize. What do you think is the most difficult one? The left one, the middle, or the right one? think I have to take my earphone again. I cannot hear you so well. Maybe it works together.
I think, Thomas, the one close to the heart is a little bit tricky. The one close to the heart on the left side is a little bit tricky in terms of access. But otherwise, they're all doable in terms of ablation. I wouldn't consider them to be very difficult to ablate. The one on the left side is slightly more difficult than the rest too.
Yeah, I think. Anybody else? Any ideas on that? The most problems I had with this one here. So this one here, one of my best friends is a heart surgeon in my department, and he always said the heart is cooling himself. Don't be afraid. So what they do during heart surgery is so the main problem you see what I had here. This lesion here
is a fissure.
You know, it went away. You know, I came here with a 15-centimeter needle. And so it went more and more to the hilus, you know. This was, I could only approach it. I show you now the final result by pressing it against maybe the bronchial wall or whatever. And you see also the main problem I had here. It was still controlled, but bleeding, which made me quite nervous here 24 hours after ablation. And so you see this lesion here went very well. And this lesion also here. So do you think one of the lesions recurred, or what lesion could have recurred, you think? The good news, otherwise I would not show it, was that we had I think we had we had a 2 years following a CT scan and PET scan, and none of the lesions recurred, or he also developed not new lesions. Meanwhile, this is more than 4 years later, and he never again developed lung metastases. So there are these positive courses sometimes, not always, but sometimes they can happen. So the first paper we published in 2011 was in Radiology for lung ablation, and in our series we very fast got the knowledge that if we have lung tumors more than 3 centimeters, we have no chance. 5 of 20 recurred. And what we also learned that if we have 2 central lesions, the risk of recurrence is also quite high. So in our institution, still the best size is 3 centimeters and lower. A lot of technology has improved. I think you all know them. Imprint technology. Meanwhile, several providers are giving you the possibility to ablate very spherical lesions, which helped us enormously because we have fewer complications, we have a higher safety. So this is, of course, much better. So after 129 sessions, you see the technical success rate meanwhile improved. The complications is minor. And one of my fellows here worked very hard in the sphericity index, which is a median of 0.1, which means that about 20% the longitudinal and transverse diameter are different, so that we are more and more getting really spherical lesions. Here I show an example of a patient, 61-year-old with a lung metastasis. We had him lying on the supine positioning. This is how we do. We have an online CT scanner, and we normally are always forced to take biopsies because, and you see what happened from the biopsy, that we had immediately a small bleeding here, and then we put the microwave antenna inside, ablate for a period of 5 or 6 minutes. We go normally up to 100 watts, and then you see nicely how the shadowing is gone, how the complete structure of the tumor is dissolved. And if you look here after the ablation, the first scan always looks a little more terrible. And but if you look at the long term, you see that the sizing of the microwave-induced lesion is coming lower, and so we didn't see any recurrence in these tumors. But we found the CT scan and CT guided ablation a very helpful technology. Here, another example for you. They offered to me a patient with metastasis from bronchial carcinoma. The left lung was resected. What would be your idea? You would go for ablation or prefer stereotactic radiotherapy. No clear opinion.
I would go straight for an ablation.
Yeah. The patient, there was discussed also on stereotactic radiotherapy, but finally we also decided for ablation. Here you see the both positioning, ablative procedures. This was a non-spherical one of the earlier size, and that 24 hours later. And you see 1 year after ablation, the patient was still without any major complication. His life quality was not further reduced, and he was even able to live in his normal life. So there was no disturbance of the normal life quality. If you compare that series in our Frankfurt series, since we have thermospheres technology techniques, the complications are lower, especially the major one, which might be a long-term tube. So we had the feeling that it's better controlled. At the final end, I want to give you some data where we analyzed our complications, and we found some things which are very clear, but I will show you one thing I was not aware of. The first thing, the pneumothorax rate is increasing the deeper we have to go with a needle. It's clear. What we always do, we do an on-site evacuation, and in the majority of patients, we don't need a long-term tube installation. Here you see a big mistake I did in my series at the beginning. You see, I came in with a microwave needle. I even hit the lesion. I was quite happy about it, but you see what's happening here. Immediately the pneumothorax is starting. You see it here. And my mistake was I crossed the fissure here. You see the fissure? And this happened to me in 4 cases. And you see here that this was nearly in 25% of patients. If we crossed the fissure, we had a pneumothorax, which was even a more difficult to treat one. So what we learned from that, always look also in the high resolution scan that you don't cross the fissure. That can help you to avoid major complications. This is again shown here. And so for patient selection for thermal ablation of the lung, we go for a size up to 3 centimeters. The bigger one we chemoembolized before. Positive is outer third of the lung parenchyma. Negative, of course, is distance near to the trachea. Close proximity to the diaphragm is also a problem. Some references, of course, Tony De Beer. He had the largest series in RFA, 566 patient, 51% 5-year survival, and show you here also some data on the references. A stereotactic group in Germany, we have a big group in stereotactic body radiotherapy. The lung 2 years lung control was 81% in 54. So at least according to our data, there was not a direct advantage performing stereotactic point. Interestingly, there's a nice study in 2010 comparing survival and ablation for stage 1 tumors, and they found that the ablative therapies had been in high-risk patients a very reliable technique. Primary tumors also surgery SBRE is in comparison shown here. But of course, if you need markers to put in with stereotactic radiotherapy, then you also have a risk of pneumothorax hemorrhage in that area. I want to show you also an example of non-surgical patients here, 87 patients from 2 centers, and they also were able to show in the NSCLC here in 2015 published 5-year survival of 58%, so which was quite high. Also here another example, and if everybody's interested, I can also email you a PDF of have done all the literature research if you need that. I think this is a very interesting study, and you see this is my certification to India. It's published in the Indian Journal of Radiological Imaging, a very nice protocol which we like to use in our tumor board for the primary lung cancer, depending on the size, the stage 1A, B, staging 1B. And here you see that at least in this diagram, you see in this, the microwave ablation in the second line. And so at least it's quite nicely mentioned. And I think this is a technology we can offer for this patient. What I think in summary, what could be the future optimization? We think that we need prospective data for the chemoembolization and perfusion and planned embolization. We are working on that. And we think we are very astonished how good our results are if we combine microwave with chemoembolization. Maybe because of the embolization, we have more decrease of the heat sink effect. The thermal lesions are larger, and the response is in that way better. And there's some new protocols we will also start in Frankfurt that we combine microwave ablation with chemotherapy. There might be synergistic effects, especially lowering the tumor burden, and the tumor-induced tumor progression might be inhibited by chemotherapy. Interestingly, also the immunologic function, and this could be an interesting factor for cryotherapy also in the future to work on that. Just to show an example at the very end, a 73-year-old male patient, NSCLC. He had a left lobectomy and he had a right pulmonary nodule. We intubated the right pulmonary artery, and then we embolized the tumor. We downsized the tumor here at the very end. Then we performed the thermal ablation with microwave. And you see 18 months after this lesion, at the beginning we had some thermal destruction of the lung parenchyma, but you see at the very end there's a very low area of tissue destruction, showing us a very effective technology. And another case with 4 tiny nodules also treated with lung chemoembolization, nicely intubated with a pigtail catheter, left lower lobe. And here you see the lesion itself after 2 months. And then we performed the RF ablation in this patient. And after 4 months, however, he developed a new lesion here, so which is shown here. So of course, this technology is not preventing after ablation that we are developing not new tumors. And here with chemoperfusion, maybe a technology to treat that patient in future. So I want to summarize. If we compare ablative procedures in Frankfurt, we go mainly for the microwave ablation. Several reasons. It's faster. We have a higher intertumoral temperature. It's a very clearly delineated ablation zone. We can use the same ablation material for maybe 2 lesions or 3. We do mostly of our patients we do as outpatients. The pain is reduced, and there's a nice example at the very end for all of you when you start doing some ablation tomorrow. This is a course of the intercostal artery, and I had once a problem with an enormous bleeding in the intercostal artery. And so if we have a CT scan, we always reconstruct, and sometimes it's enormously how far the intercostal artery can go down, and this is maybe the reason why you sometimes might hit it. So what are open questions? Of course, I reported you a lot of my personal experience. What is the best chemotherapy agent? How we can improve the application via the bronchial arteries? That's something what we want to do on. And this is an example. Unfortunately, you cannot see me here in Frankfurt, but I think all of you, we are already on a joint venture currently with Corona. Most of our practice is massively reduced, but if in future somebody is interested in doing further research on the topic of lung, we would be very interested to cooperate or have a fellowship here. Thank you for your attention.
Thank you, Dr. Thomas, for this wonderful talk. So I think, Dr. Thomas, if you can read some questions in the question and answer box, you can read the questions and can answer that, or
Okay.
if you want,
yeah.
So meanwhile, can I start asking a few questions, Arun?
Okay.
Sure. Why not?
So as usual, Thomas, fantastic talk. I enjoyed that a lot. And also a prayer from all of us in India for the people in Germany. I know that everybody is suffering, and I know that you guys are doing very well, but it's a prayer from all of us here in India for the people in Germany.
Thank you. And how is the situation in India? I think it's not so bad like in Germany, or?
Yeah, India, it's so far we are not at the peak. So we are maybe 2 weeks away from the peak still. But yeah, the numbers are not so high. So just coming back to your talk very quickly, there are several questions, but a couple of things that I wanted to quickly clarify. You know, you have always preferred to do a transpulmonary approach, doing TACE both for primary and for metastases. Professor Shinichi Hori, as you well know, does it from the arterial end. Now, is there anything in your mind that how you triage in your thinking that maybe I will go arterially first in this patient, or is it based on the CT angio? How do you decide that I'm going to go pulmonary first here, or I'm going to go arterial first here?
Thank you for your question. Yes, if we are able to have the patient with a CT angiography, that is extremely helpful because we can then see the diameter of the bronchial artery. And I think in summary, we can say for the lung metastasis, the pulmonary artery, in my opinion, is the best technology with the lowest risk, because you have a very easy approach, and the response rate is not that high, but as I showed you, in about 2/3 at least, you are able to reach a standstill of the tumors.
Stable disease. Yeah. Okay.
In the primary lung cancer, you are right. It is maybe better if you are able to go to the bronchial artery, but their CT angiography is helpful. If you have a
flush
4 millimeter artery, if you have a flush there, it's a good technology to use.
Okay. Now the next and probably more relevant question to India is that, I understand that in Germany, you get the tumors at a much smaller size. In India, if you go to any lung MDT, the average presentation is a T3N2 or a T3N1 tumor. I guess it is also true in Germany, but in India, it is the tumor present at a much more larger stage, and the need for palliation, the need for symptom control, like you showed in a few cases in your talk, is very, very important. So firstly, A, what is your experience of treating larger tumors with this? And B is, like, for example, whatever little I have tried in patients who are bleeding, for example, there is a risk of an ulcer or a perforation, or basically the tumor giving way to make a fistula with the bronchial tree. What is your view on those grounds in terms of treating larger tumors for palliation?
Yeah. In the larger tumors for palliation, if we talk on primary lung cancer, we have never seen. I've never seen a fistula. I had a patient who developed a reversible spinal problem. Even there was a big bronchial artery, but maybe I made a mistake, or I don't know, in that area. But I think especially for palliation, if you have bleeding patients or patients with dyspnea, I think the chemoembolization is a good technology. And if you work closely with your thoracic oncologist, mostly they are very, here in my institution, they are very interested to help them. And together with them, we always discuss what is the best drug to use. It can be carboplatin, it can be doxorubicin. We have seen quite good palliation response in these patients, especially if we have bigger tumors. We don't see them so frequently in Germany. You are right.
Sure. Thank you. Thank you.
Can I ask one question?
Naveen, go ahead.
Yeah. So that was an excellent talk. My question is regarding the choice of the ablation modality. In case there's a lesion close to a vessel, and you have RFA, microwave, and cryo. So what is your choice? It's a small lesion, maybe less than a 3 centimeter size lesion, but close to a blood vessel. So, and you have all three modalities. Which one would you choose?
So I would prefer currently microwave. We do a lot of cryo in primary breast cancer. We do it in renal cancer, and I think I've seen in renal cancer. I've seen from very little, but from time to time I've seen the bleeding especially in the warm-up period. So in the lung parenchyma, I would be very careful with the cryoablation. If you have outer thoracic wall lesions, cryo is excellent because it's painless and so. But in the lung itself, I would still go for the microwave, and the new technology, either thermospheres or there are some new Chinese systems. They're, you know, you're very fast and
ISVIR.
yeah.
So microwave is your choice of ablation.
Yeah. But you know, some groups have a lot of experience in RFA, especially the French groups, and I'm fascinated how good their results are with RFA. I always had problems. I don't know why.
We have a large experience with RFA, but I must admit that since for the last 5 to 6 years of using microwave in the lung has superseded RF. So unless we are in a position where it is very close, you need to be very accurate with your needle positioning, etc. We are almost always using microwave.
Okay, yeah, it's
so there are some questions.
So when we do, I have a question, Dr. Thomas. So when you start the chemoembolization and start injecting the chemotherapy, is there anything that the patient feels or patient tolerates the procedure very easily when you inject the chemotherapy along with Lipidol?
Thank you for this is a very important question. Interestingly, they sometimes they report a taste, you know, because they have a taste, like if you use, for example, cisplatin, it makes a taste on the tongue. But honestly, we have never seen a severe in the pulmonary artery embolization. We never have seen a severe side effect or lung infarction, lung embolism. While using the beads, as I mentioned, I had seen 2 severe lung infarctions. So the beads we did not follow, but maybe it was our mistake. I don't know. But I had seen 2 major lung infarctions, which were very painful and took us a lot of problems.
Dr. Thomas, there is a lot of question and answer session on the lower panel. So you can just click on that and you can answer all the questions.
Let me see how I can. I leave
on
the presentation.
The lower part of the screen, there is just adjacent
Q&A.
Q&A, yes.
Let me see. I don't know why.
Okay, we can read it out to you.
Adjacent to the participants.
Yeah, okay. So there's one question: how we do the follow-up imaging of the post-procedure cases. Normally, we use CT scan. In some cases, for scientific studies, we also use MRI. PET-CT I found not so very helpful. Maybe you have different opinion on that, but in the early phase it was never reliable. The second question is balloon microcatheters. Not in any case. If we have complex relationships of the pulmonary artery, I sometimes use ballooning, but not in all patients. For bilateral extensive metastasis, I would always only one session, one side, or multiple sessions on one side. We never treat both sides in one session, but this is maybe due to our personal experience. The second question from Irana is on how often bleeding requires any intervention. I've seen only 2 cases of intraprocedural bleedings, and we were able with the embolization material to get it under control. If somebody's interested in the chemoembolization protocol, just send me an email and I can send you the protocol. I think the dose I always discuss with my thoracic oncologist, because all these patients had underwent chemotherapy treatment before. So we need good data on kidney values and the bone marrow capacity. The quantity of lipidol is between 8 and 10 ml. This is very well tolerated. Never made us any problems. Very important question: chances of pulmonary embolism after TPCE. Interestingly, even we did the follow-up, we have not seen one in more than 200 patients. No anticoagulation necessary after TPCE. Balloon catheters, I would not go more than 6 or 7 millimeters. More we did not use in our series. stabilizing the MVA antenna, that is a challenge, absolutely. My greatest mistake, like I showed in the one patient, is that I always like to use a too short antenna, because I measure, let's say it's 10 centimeters, then I maybe go for 13, but these lesions are movable in the lung. At least maybe others can comment on that. It's enormously how such a lesion can move in the lung, and suddenly my antenna is too short. So we do free breathing, that's right. Another question is, do you whether we use PVA particles? No, I have no experience with that.
What is the minimum time gap? What is the time gap between each cycle of TPC?
We do 4 weeks, like in the liver. The question is from Atul Mishara. What is the max number of metastases to address by TACE? Ours here showed that if it's a quantitative number, but if the metastases are more than 10, the survival results were bad. The chemotherapy drugs for TPC.
In other words, that even if there are, say, 5 metastases on either side,
you know, if you have 5 metastases on each side, it is still something we would perform, yes. So, but if you have 10 on the right and 15 on the left side, it is under question. It depends on the tumor. In colorectal cancer, maybe we would discuss it. In breast cancer, no chance. So it's depending a little bit on the underlying histology.
And Thomas, if you are doing multiple metastases in one lung, let's say you've got 10 metastases in one lung, you would go segmentally into each of these vessels.
Yes.
Yes.
And
So, and is there a maximum like dose? Obviously, like in the liver, do you have a maximum dose? I guess your oncologist will tell you that you will not exceed this dose.
Yes, you know, but normally we made good experience with mitomycin, which is a drug. I think it's not so frequent in India. So there we go up to 10 milligram. Cisplatin we go up to 70 milligram. There I would not be afraid. A drug which is very helpful in the lung is irinotecan. There we can go up to 100 milligram. This is the highest dose. Yeah, if all correctly.
Yeah.
In breast cancer, we found gemcitabine quite helpful. There we go to a dose for about 800 milligram, quite helpful. In sarcoma and in lung cancer, carboplatin, the highest dose we were applying there was 70 milligram, because my oncologist always afraid that we get a lung infarction.
Do you always embolize? Do you always embolize or just chemo infusion?
No, mainly we do embolization. Yeah.
Okay.
Yeah. What is the most common complication post chemoembolization? I think what we have seen is a rise in the temperature. I've seen 2 severe allergies. One patient had to go to the ICU, but it was maybe also a contrast allergy, we don't know. But temperature elevation is important. We never have seen an abscess. Okay, and my email, I think if you Google Vogl, Vogl without an E, you have me immediately.
I shared your email ID.
Yes,
already shared.
I shared your email ID with all the.
But I can share that. Yeah, I send a good email where I can answer. Yeah.
You are not difficult to find, Thomas.
Anesthesia used for chemoembolizations and for ablations.
Because in Frankfurt we have Germans here. We are very strict people, so we do all with mild sedation and in local anesthesia. We nearly never use general anesthesia, because the minute anesthesiologist in Frankfurt is €3 per minute. So my budget is over after 1 hour. So. It's the most expensive specialty. If I need an anesthesiologist for 2 hours, my budget is ruined. So, but in India it's better, I think, or they all work for you, so it's
far better.
We have anesthetists covered lists, yes.
Yeah.
But yes, How are we doing for time, guys?
You do a lot in general anesthesia, I assume, or?
Yeah,
We have an anesthetist.
Mm-hmm.
We have an anesthetist present.
Oh,
It
yeah.
is not that we do it under GA. It is on a case by case basis. There is generally the anesthetist sees the patient, looks at the patient, and they takes a call. Obviously, lung in the UK, as you know, we used to do single lung ventilation because that can make the lung still if you do single lung ventilation. So that used to be a great advantage. But in here, like you, I do mostly under sedation and local anesthetic, except in certain situations where the anesthetist says this prone position, this, I'm not happy, so we are going to do a tube, and then they go and do a tube. So we leave it to the anesthetist mainly.
Okay, and you can afford that. I could not afford it. It's they are.
Yeah, no, we are lucky
and,
that way.
And due to Corona now, the anesthesiologists, intensive care people, they are out of
even busier. Even busier.
They are busier, and they are now the kings of the medicine.
Right. Yes, of course. Yes. Great.
Next question is
We have
SBRT
time?
lesion in metastatic lung lesion. I think that is.
No, there is a good question on irinotecan TACE in liver, the causing spasm in the, as you know, irinotecan is very painful and can cause spasm in the liver. So, so talking about intraarterial lignocaine and GTN that we use in the liver for debris, is it something similar that you do in the lung? I think that is the question.
Yeah, we did the first DBRE cases here in Europe and in the liver, and this was quite successful, but it was so painful. And due to the fact that we have a lot of outpatients, or nearly everything done on an outpatient one-day basis, this was great to tolerate. And what I mentioned was for the lung, we also used a DBRE protocol, but it was disaster. It was, first of all, painful, and it caused a lot of lung infarction. So it was not a good thing.
So that's why you said that you don't use beads. You said that
no beads.
You don't like beads.
And honestly, also in the colorectal cancer in metastasis, the pain problem it's so severe in, I don't know, at least from my pharmacy, that we mainly do TACE or we do CERT, but the DBRE in Germany is not so distributed like in British countries.
So Thomas, just a very question on the edge of pushing. Have you done a CERT in the lung for, not for a HCC metastasis, but for a primary lung cancer or for metastases?
No.
Have you done a CERT?
No, no. Maybe the guys from Chicago, they tried it, but the thing is, it's getting out of control, you know. So it's.
So we have some more questions in the question and answer session.
I look it here. Ja, let me see. Ja, okay. Spasm, ja, das haben wir schon. Dann genau, the emulsion doxorubicin. If you go for example, 50 ml doxorubicin, you have we have then an emulsion of about 20 ml, which you can apply quite good. Then there's a question to rule out pulmonary shunt to prevent systemic shunting. What we always do is a two-plane angiography. Maybe I did not mention that because of the shortness of time. I do always a two-plane angiography of the lung to really be totally certain that you don't have any shunting, because that would be, of course, a disaster, because then you have the lipidol or all the what you are injecting, you have then in the main circulation. So I think that's very important. You need a really machine-based pulmonary angiography, and it has to be in a good quality. And we always do it in two planes to be totally certain that we don't have any shunts. Okay, there was this question, and I think catheter, we are using catheters we use for the intubation normally with a headhunter, and then we put a guide wire in, and then a balloon catheter, 6 millimeter balloon catheter, length of 20 millimeter. That is a good ablation. I think a big question is by Brad Gupta at 231, SBRT versus ablation metastatic lung lesion. This is a daily fight in the conferences. Interestingly, my experience in our series, in our hospital, the SBRT in the lung is not so, they have a lot of local recurrence. We have a very strict tumor board. The patients are also followed always by the tumor board. So even after 1 year, the patient goes back to the tumor board. So I think the advantage of ablation is that what we are offering, we give them a histology. So we can give them a histology for genetic analysis, for chemotherapy drugs, whatever. And what we do, we take the biopsy and perform an on-site ablation. And my dream is that we are working with a new pathologist, that we take the sample from the biopsy. It's video based, that the pathologist looks at and macroscopically, is this a tissue? He can most probably look at the tumor tissue, and then we follow the ablation. But mostly we do the biopsy and ablate the lesion immediately after that.
Like in the kidney, yeah.
There's one more question. Do you do routine pulmonary function test evaluation before?
Yeah, there's a question on pulmonary function. No, we don't do that. I've never seen that the pulmonary function was significantly reduced. Maybe if you decide for a bilateral chemoembolization, but normally we don't do that.
But
I think just a comment.
When you do bilateral chemoembolization, do you do it in the same sitting or you do it in a second sitting?
No, never in the same. We always do. We only treat a single lung. This is how we also, our ethical and tumor board committee also demanded it from us, so that we don't have the patient in a more critical situation.
Correct, correct.
So regarding lung function test, very quickly, just the only exception to what I think what Thomas was saying would be that if the patient is a surgically rejected patient for a primary lung cancer with a poor lung background, where there the FEV1 is important, but otherwise for metastases, it is not routine to do a lung function test.
What about cavity formation post microwave ablation?
That's a good
question.
How
common is that?
That's a good question.
What do you expect?
Yeah, that's a very good question. I've seen not so many, but we had 2 cases with a severe cavity problem and then infection afterwards. This has improved, I think, with the new technology of microwave, with the newer system. I've seen it less, but of course it's still a problem. I have no idea, or in our series we could not see what are the risks for that, but of course it can be a bigger problem. And infection is, in my opinion, less a problem. What we sometimes have seen, maybe you are also all very, very experienced, you can also emphasize this. We have seen some patient with the pain after microwave ablation in the chest wall, or even if you have not been, there had just be pain, a long time pain. I've seen now twice in 2 cases, which really caused us a lot of problems, a nerval pain, or I don't know.
Yes.
Has anybody seen that also?
Experiences.
Yeah. That is yes, of course, Thomas. And the main reason for that is that particularly with the older microwaves, where it was an oblong ablation margin, if the ablation margin would sometimes incorporate part of the chest wall, at proximally, and if there was a intercostal nerve, for example, then that would have also got burned. So yes, I've had that as well. Intractable chest pain, where in fact had to do alcohol, blockage of the nerve. Yes.
Yeah, we need pain. We need pain specialists. I remember one case. It was, and he was a colleague. First I didn't believe him, but he had a terrible pain. It was terrible.
Yeah. Okay. Thank you.
Any more questions? SBRT we had. Is this in India also a big topic? SBRT, yes, or?
Yes.
The problem is they have the control of the patients, because in colorectal cancer they treat the rectal area, then they do the radiation of the liver, then they do the radiation of the lung. So yeah.
It's more of a problem in pulmonary cancer,
primary lung cancer,
primary lung cancer, as opposed to
Metastases.
colorectal.
Yeah.
Okay, but in primary lung cancer,
shouldn't call it a problem. I mean to say that the competition is in primary lung cancer.
Yeah.
Okay. But the advantage is that we can provide them a histology, you know. And if we are in with a needle with a microwave, you know, then we. You know.
Yeah. Also, SBRT often means 3 sessions, whereas ablation is done in 1 session. So there are advantages, and also the lung function reduction with SBRT is more than with ablation. So there are advantages, but as you say, there is a perceived notion throughout the world that for primary lung cancer, SBRT is superior to ablation. So that because the randomization of that data is better than the randomization that we have in terms of ablation. So.
Yeah, and they are better organized. They do it now in a very standardized technique, and the microwave, you know, we have now 10 systems in Germany. We have 10 different microwave systems. Everybody does it different. So it's in Germany we try now to, I'm in charge of the CIRSE. We try to get an international registry for lung ablation, but it's so difficult. It's so difficult.
So there's a question, Thomas, last question. If you have got a 5 centimeter lung tumor, you would do the TACE first and then you would ablate, correct? Is that that your order?
Yeah, in 5 centimeters, I could not ablate it. I would.
Yes, of course.
I never managed.
Okay, so the primary lungs, what's the maximum size you choose?
Also, I would say, if there's no other option and I'm in a good shape and I have slept very well, we would maybe do a 4 centimeter lesion. But I think 3 centimeter. My problem is my tumor boards goes over years, you know. And if I have a recurrence, they show it to me 20 times. The first tumor board, and it comes 6 weeks later. You know, it's, I don't know. In India, it's maybe all better, but in Germany, they show you your complication. They show you every second tumor board. You know. So,
yeah,
it's the same everywhere, Thomas.
It's the same everywhere. So I should not move to India. No.
We should be more aggressive.
You know, and the surgeons, they are so different, because you know, if they have a complication and it is a little one, the patient not coming again in the tumor board. He's not shown up anymore. But you know,
no, it's also always because of some other reason, you know. The assistant operated, or it is something else.
So or the surgeon, if I had a bad case where I helped recently, they did a lung resection, they did not get the lesion out, so then they said, and the patient was he was still in a surgical phase, you know, so they said, come, we do it fast so that the lesion is then removed. And then I had a patient who was already freshly operated, so of course what happened, he got a complication, he got a infection there, you know. It ended that it's now my complication. No? So yeah, it's my complication now. So
of course.
Yeah, they didn't find it, and I did it, and now it's my complication. It's my abscess and drainage, and so then they do it. But I see it the same everywhere in the world.
Yeah. Right. Great.
I think there's one last question.
I think he's already.
I think the largest size is not clear to me. The largest tumor you would treat with chemoembo. I think that's what Dr. Ajit was asking, right?
For the chemoembo, I would say there is, if it's a metastasis, I would try even very big ones. If it's a primary tumor, I would be.
Any size limit?
I would say our size limit is 7 centimeter. I've not done more bigger tumors.
Okay, sir.
How common is bronchopleural fistula with ablation?
Bronchopulmonary, I've not seen. we had more problems if we treat. We have more biliary pleural fistula. There, I had 2 cases in my career. That was also very bad. If you do ablation of the liver, and then you suddenly have a pleural, that is very bad, very bad.
Okay.
Okay, thank you, sir. And it's a wonderful session, and we have a lot of questions, and you answered all of the questions. And I thank you, panelists. Dr. Shubhro is the scientific chairman of ISVIR. Dr. Arun Gupta is the secretary of ISVIR. Dr. Girish is the past president of ISVIR. Dr. Kunal is working in the Tata Memorial Hospital, Mumbai. Dr. Naveen Kalra is a professor at the PGI Chandigarh. He is in a These all are the onco-intervention radiologists, and they are doing the mostly the onco interventions at their centers. I thank Dr. Thomas Vogl again, and maybe we can have some another day some other lectures from him. Thank you, sir.
Absolutely. I have some interesting topics, and next time my video camera will also work. I don't know what happened here.
And also
okay.
Stay safe. Stay safe.
Stay healthy and sane. Okay. Yeah. Bye bye.
Okay.
Bye bye.
Okay. Thank you.
Bye.
Bye, guys.
Bye.
Leave meeting.